When we presented the results of NeoAvAx just now at ASCO, it's important to keep in mind that this is a single-phase study. It included 40 patients. That was a Simon two-stage design. And the primary endpoint was clinical response in the primary tumor. So we wanted to see a RECIST 1.1 response. Whether this is a truly important endpoint is another question, but hard oncological endpoints like, for example, disease-free survival and overall survival are best tested in a randomized setting. And in a single-arm study, you're more looking for efficacy markers. Some have propagated, for example, to look at pathological response. Now, the difficulty with kidney cancer is this has not been tested before. We know that kidney cancer has in itself already a high degree of necrosis. And we hypothesized that it may be quite difficult. So that's why we wanted to see at least a partial response rate in these tumors. And we also know from published data from Javelin and also Checkmate 214 on patients who had been treated with their primary tumor in place, that this partial response in the primary tumor or any kind of downsizing to a certain degree correlates with the response at metastatic sites and the outcome. So I think the most important next step in a single-arm study would be trying to identify potential candidates for biomarkers that would allow us to decide at the onset of the treatment who will be a candidate who responds and who wouldn't. Now, you can do this with imaging. We had an interval imaging, that would be an imaging biomarker at 6 weeks. But then you're already halfway down the road, aren't you? So what you would like to do is some sort of circulating tumor-free ctDNA could be an option, but other, for example, interferon gamma expression markers, or the expression of the immune profile at the onset of therapy. Others have alluded already in papers, but they did that from biopsies in the primary tumor, that the T-cell repertoire you have, if you can demonstrate it's clonal and cytotoxic, then this is much more likely to be expanded by immune therapy, and those patients are probably more likely to respond. But this has not been shown in the peripheral blood by now. And as you can imagine, a biopsy may not represent the whole picture. So to sum this up, what I just said, it is questionable whether we will be able in a 40-patient trial to actually find a pre-treatment biomarker. But if we were to, then the next step, in my point of view, would be to test this on a larger scale. The other next step, I think, is important to figure out whether patients would need adjuvant therapy after neoadjuvant therapy, so kind of sandwich therapy. The disease-free survival in our series, or at least the recurrence rate of 32.5%, suggests that this may be something to ponder, as these patients may have benefit from continued therapy. But let's also remind us that disease-free survival rates are very similar to adjuvant therapies. And finally, I think, as I said already before, there would be a time where we would test this against the potential new standard of care, which would be, I mean, the field is evolving, but a new standard of care currently could be pembrolizumab as adjuvant in patients with high risk of recurrence. And it would be interesting to set up a trial where at least this concept is tested with a short course of neoadjuvant treatment followed by adjuvant treatment versus adjuvant treatment alone, for example.